that I ever saw the report. I think it just really spoke to, I think our grant was around $250,000. We only had 23 patients at the time, at least on the dockets, even though we thought we had a great consortium with the Department of Health, and you were using the funds to provide primary care to patients who were actually on the Department of Health rolls. They just, my understanding at the time was that they felt that we just didn't need the money anymore. I don't know if you've ever been privy to other documents.
No, this is Wilbur Smith, the ED. As like Dr. Francis, I've been here 2.5 years now, and I never heard the reason why the funds were removed or the grant was removed, other than the fact that the numbers did not, this is what I heard, that the numbers did not warrant the grant actually been awarded to the center. And so it was removed before I got here. Now, what we intend to do, however, as we get better with what we do in terms of managing the center, is to reapply for the Ryan White grant.
Okay. So that's one of your goals. And
yes.
When in what time period? When are you looking to do that?
Well, at the next budget cycle.
Okay.
Which will be for in 2013 cycle? Yeah, it will be the 2014 budget cycle.
Okay. And right now, how are you doing with managing those patients in terms of paying for the services? I know in your application, let's see, I'm just looking back at it.
We receive funding from the local government, the general fund, that adds to our HRSA funding. And so far, as Dr. Douglas said, we have been able, since she's here full time, we've been able to integrate those patients into our regular roles, and we've been using the funding, our other sources, as well as their own self-pay resources, meaning that some of the patients have insurance, some of the patients have medical assistance, and some of the patients have to on their own. We've been working with the Department of Health. They still have Ryan White Part 4. They're able to reimburse us for some of the women's health care services. All the patients are interviewed, even the 50, 60 on our rolls are interviewed by the Department of Health social workers, and I think probably almost all of them are on the ADAP program. I don't know about all, but almost all are able to receive their medicines for free. We also, on a case-by-case basis, are still able to provide, but from our general funding budget and our patient resources, some of the primary care medicines. Say, for example, some of them, because they're unemployed or underemployed or even underinsured, have difficulty purchasing their antihypertensives and their diabetic medications, and we are able to assist them to a large degree. They are, however, now assessed and put on our same sliding scale and are receiving bills for that, and some of them are not accustomed to having received the bills because, as I said, we did have the funding. The program, whether rightly or unrightly so, was almost administered as a free service where the clients were not required to pay anything. So we are having some difficulty having them make the transition between, if they have resources, but they have to use them, whether they're insurance, medical assistance, or self-pay. Even some of the patients who have insurance are, because it's a very small island, there's a lot of stigma associated, or very reluctant to reveal their insurance sources. We have still a couple of patients who refuse to go to the pharmacy to get their medicines, and our head nurse is still nice enough to go to the pharmacy and get the medicines for them. So we're managing, and that's another reason why we wanted to see what you all had to offer as far as resources and expertise as far as transitioning these patients into realizing that we are here to help, but not necessarily to carry the whole burden of the cost.
Right. Okay. And you also mentioned that you do receive some support from the Department of Health for Part D to cover some of your women's services. How many women do you have? Do you know?
I don't know off the top of my head. Dr. Douglas?
I'm not sure, although I think most of them are women. Probably about 60% are women.
60%?
Yes, 60, 60.
Okay.
Of the women with HIV or of your total clients?
Total count of patients with HIV.
Is that the question you're asked, or you want to know?
Well, no, yeah, I wasn't sure if you meant 60% of your HIV clients or 60% of your total patients.
No, 60% of the HIV clients.
Mm-hmm.
Okay. All right. Well, then,
Did you talk about why you applied?
oh yeah, and so I mean, you were interested in applying. You applied because you're interested in how we can help you increase your revenue. Is that primarily the reason why?
A part of it was revenue, part of it is capacity building, because we know that there are other patients out there who may or may not be being tested for those sort of reasons, to build the capacity to bring them in, and also to make sure that even though Dr. Douglas and some of the other doctors who provide HIV care, to make sure, just to pretty much optimize the whole program to make sure that we were delivering the best medical care, up-to-date medicines, increasing the capacity, helping deal with stigma, because as we said, a lot of folks don't even want to come in and are sort of hiding in the community. So we really just had a multifocal goals.
Okay. This is Mona Moore. And first I was going to ask you just about your location, because on the application it just says Tutu Mall. It doesn't really say what town the clinic is in.
We're on St. Thomas, the island of St. Thomas.
No, but within St. Thomas, it just says Tutu Mall for your address. It doesn't say what town in St. Thomas. Like, are you on the Red Hook side or where?
We don't have towns in St. Thomas.
Have you ever been to St. Thomas?
St. Thomas is an island.
Yes, I have family there and in St. John. I was just wondering, like, then if you're not going to call it a town per se, then just geographically, are you central in the island or
part of eastern part of the island?
Eastern. Okay. Well, there was one thing as we were reviewing your application, and we will go through the assessment step by step on this call, but we also went back and looked at your application, and I just wanted to highlight the fact that the primary purpose of this project is HIV clinical treatment training support. And as we were going through it, since you have such a high level of expertise at your center now, as we go through it, we just want to be sure that there is some clinical component, treatment component to the support you would like to give us, so that we're in compliance with our own funding requirements. Okay?
Could you explain that, please? I wasn't really clear on what you meant by that.
Well, I guess it's comparative, among the many different health centers that we are working with. Most of them who apply to this program, because it's a treatment, HIV training program primarily, they are interested in being aggressively being a part of our HIV clinical training. And you rated yourself as stage 3 comprehensive care, and most of the people that we work with are much lower down on the spectrum in that entire range of stages. And so the fact that you have a HIV specialist and such good collaboration and coordination with the AATC, we were just wondering if, in fact, what you were hoping to get from the clinical part of this project.
And were you, and I apologize for getting a slide set to you late, but were you able to glance at the slide set that we put together, just giving you a bit more information about the HIV training package and what's available clinically for this project?
Actually, no, because I think I just got them a few minutes ago. The slides that you just sent at 11 or 10.
That's it.
Yeah.
That's okay. Don't worry.
No, that's fine. And we were going to have another call to discuss the clinical offerings in depth. We just wanted to, if you had an opportunity, we wanted to allow you to review that prior to this call.
Okay. Well, so let's just start going through the assessment form, the clinical part of the assessment form, and we'll start with the part about the care team, question 4. So you've listed Dr. Douglas and Dr. Thomas and Dr. Richards.
Yeah.
In your application, there was reference to someone named Ty Hunt, who is an ID doc that you also work with closely.
Yes, she just moved to the island probably about 6 months ago, and she's now the new infectious doctor at the Department of Health, and we do have access to her.
Good. Okay. Good. Now, I noticed that Dr. Douglas, you list yourself on this assessment form as being the performance improvement leader, but usually, often the medical people are the clinical learning leaders, which is called the CLL, and they're more in charge of the clinical training part of the program. And I was wondering, if you're designating yourself as the performance improvement leader, will you also take the role of CLL?
Well, do you normally have one person take those 2 roles?
No.
No. And Dr. Wright Francis, you're the clinical learning leader for St. Thomas. Right,
well, I think maybe I didn't understand the questions exactly, and that's what I was hoping we'd get a little bit more clarification on the calls. I serve as a medical director, and I'm an OBGYN, and we do have a high-risk OB doctor who does most of the higher-level HIV care, and just sort of what you requested about somebody who would be a champion for learning. As a medical director, sort of being in charge of all the clinic, I knew that I wouldn't probably have enough time to devote an extra 4 hours to this project. So that's why, based on the time constraints, time limitations and suggestions you put beside, I thought that I would be more as a champion as I direct the quality improvement type things for the whole clinic to integrate the HIV parts in there, and that Dr. Douglas would really be the performance improvement leader because she sort of is the head of the HIV clientele and would have a little bit more time to doing that, to really fleshing out all of the projects. But I think, there may be some blending of roles and overlap of roles as we go through this.
Yes, and certainly with a smaller staff, there's no way to avoid that, but we just would like to be sure that neither one of you are going to be too overwhelmed. And if
well,
one person
like
is
I said, I
two
knew
of
that I didn't have an additional 4 hours to do it.
Right.
That's nominated her as the 4 hours because I usually do that. I spend that much time doing quality improvement, but it's for the whole organization, not just related to the HIV patients. And that's why I thought that Dr. Douglas would be more suited for that role if that's truthfully the amount of time that it would require. She is here 40 hours a week and has about 8 hours of administrative time, in which part of that is for quality improvement. And then I know that there are probably other things that I would have had her do, but because of this grant and the time constraints that we had on it, I certainly have asked her if she'd be able to spend half of her administrative time working on the HIV patients. And I think she spends a lot of it anyway because she works LPN, case managers, and in addition to having the other 4 hours to work on her other client load. So that's why we split it up that way, and hoping that way it wouldn't be as overwhelming. And I think the clinical, even though Dr. Douglas has gone through the training, I think even at the time we wrote the grant, Dr. Thomas hadn't even gone through the training as yet. Dr. Richards, our other family practitioner, has not gone through the training, and one of our head nurses has, but even the case manager, Jessica Pena, who works with Dr. Douglas. I think she went to one ATC event, but it probably was even on a higher level than she would. And what we're hoping is that as Dr. Douglas develops more expertise in care, part of the expertise will be in getting the whole staff involved, including the nurses and the case managers, as far as doing the HIV care. So, and that's something that we try to do organizational-wide, so that everything is not just left to the doctors. Even the nursing assistants, when the patients come in, can look at the sheets that we have in the chart to say, oh, you haven't had a pap smear in 6 months, or you haven't, your need for your mammogram, or, did you get your bloods drawn already, to really just sort of make it be more of a team approach, so that everything is just not left to Dr. Douglas. Even though she oversees it and makes sure it gets done, we want to make sure that everybody is brought into the training to really, so that I think that was one of our goals, is to really make everybody very HIV conscious. One of the big things that we've done over the last year is really kind of, I won't say that we're completely opt out, but we really, HIV testing is even a part of our vitals right now to make sure that everybody's tested. So we're really trying to make the whole organization be very HIV minded.
No, I saw that, and that's really wonderful. In fact, I'm really glad to hear you say that, because one of our approaches to our HIV training is called whole site training, and it's exactly what you just said. Because, just training up a couple of the prescribing clinicians to do the treatment, you need much more whole team support. So that's exactly the kind of training model that we have. But it wasn't really clear in the application exactly what you had in mind.
Okay.
Will you be wanting some of your two docs to get additional HIV expertise?
Absolutely. We'd like the whole team.
Okay, perfect. Then that really is quite a good fit. And when you say that Dr. Thomas and Dr. Richards went to the training, you mean some local AATC training, or which was that?
Dr. Thomas and Nurse Hawkins, our head nurse, went to an ATC mini residency, I think just late January, early February.
Oh, that's a great course.
Yes.
Okay. Okay, that really is a great.
That's
the 5-day one?
They said after they finished.
What'd they say?
Too worn out to even shop. If you're from the Virgin Islands, you understand.
No, I do know.
Here.
I know, and you go home with your suitcase empty still because you couldn't even get to the malls in Miami, right?
Because he said they were too tired.
Yeah. Well then that must be an intensive course if you couldn't even get out for the shopping. Okay.
Dr. Douglas has been trained.
Douglas went several years ago, right?
About 2 years ago.
2 years ago.
Yeah.
2 years ago?
Yeah, and so to us, comparatively speaking, as I said, among all of the centers that we work with, you really do have a very good level of treatment expertise already on your site. But surely we'll be able to help to complement and supplement that, because we also notice that you do have a very strong relationship with the Florida Caribbean AATC, and that's such a plus. So we're just sort of saying, okay, we have a very kind of specific package of training and an approach, and just trying to look at what we have to offer and what you already have, and seeing, where we might best support the expertise, considerable expertise that you already have. And correct me if I'm wrong, but by having about 60 HIV patients, isn't that about 1/10 of all the positives in the whole of the 3 islands? You have a significant amount of the patient load.
Yes.
Yeah. Okay. So it's really important. All right. So we're pretty clear on who your care team is. Some of them have been trained up very well. You have the strong links. So our goal, technically our goal is to move the staff at the center where we're working one stage 1, stage 2, stage 3. If you're already at stage 3, which is how you rated yourself, then we just couldn't quite figure out how we could take you higher. But I think we'll be able to work something out. You mentioned that you have a new EHR system called NeoMed that you put in at the end of last year?
No, that is not correct. It is not implemented.
No?
I may have indicated that on the application because
on the application, yeah.
I thought that it would be in place by December, but we've had a few snafus.
Are you still thinking of doing that?
Oh, yes, without a doubt. It's just that the implementation date has been pushed.
Okay.
Do you know when that date's going to be?
Will be implemented before the end of this year.
Okay, and the reason that it's of interest to us is in other places that we are working, when a CHC is involved in putting in a new EHR system, it takes a lot of the clinical staff and the other staff's time. And also you mentioned that you were having a new capital project and expansion in oral health, and so we're just looking at those other things that you have going on and wondering if over the year they might start to crowd out the time that you have to do the work with us?
you know, it's so funny that you say that, because as we walked into this room, Dr. Douglas said, you know, how do you do it all? And I said, because of you all. 2 years ago, I was really the only physician here, and not even quite full-time, and we had a full-time physician assistant. But over the course of the last year, with Mr. Smith's leadership, we've been able to bring in Dr. Tess Richards, who we listed on the application, who's a full-time family practitioner. We have Dr. Douglas, who's a full-time internist, who actually just came on board full-time in September. I have a pediatrician, Audrey Thomas, who just completed the training. She's here about half-time. We have the physician assistant, and I have another part-time family practitioner. And we've already started to, each one of them is a leader and are taking on separate projects and taking the leadership of those roles. From a clinical point of view, as far as like the PA is really taking on the lead in the obstetrical department. So because we have so many leaders and so many folks who are dedicated to leadership and not just coming in to work and being done with it, who are interested in taking the leads on these type projects, I feel very confident that we will be able to complete everything. I think everyone is very committed. My 2 family practitioners are just 2 years out of residency, so they are hot and raring to go and been in places where a lot of quality and performance improvement have been in place. Dr. Douglas had been in practice for many years. So from a clinical point of view, I think we are well staffed up and have a team that, like I said, who is committed to taking the organization to the next level. If it weren't for that, I would completely agree with you. We are also blessed that we have a COO and a CFO who are taking control of those other projects as far as the medical records and the expansion project, and so that's very helpful. In addition to the executive team, we also have a great nursing team. Up until 6 months ago, we had a nurse who was doing immunizations, our head nurse. We brought another RN. So everyone is told that they are expected to be a leader and to get things done and to be self-starters and self-motivators. We still have some issues like every place else, but because I think we do at this point in time, knock on wood and praise the Lord, have a great team that they really are very proactive, and I am just able to kind of say, this is what it is, and it comes back to me. You know, I give a seed, and it comes back as a tree. So I think that's
wonderful.
Confident that
yeah, actually, it's very
yes.
It's very encouraging to hear your enthusiasm. It really is. The PA is not going to be involved in your care team?
Well, you know, as I filled out the application, I mean, I was almost tempted to just put everybody there, but then I didn't know. But I think right now she does most of the OBGYN care and does work very closely with the high-risk doctor. I mean, you know, just some things weren't very clear, and I wasn't sure, you know, whether or not, because I really just wanted to put everybody, honestly. But certainly, yes, if she can be included, I would love for her to be included.
Yeah, that would be fine. We welcome you to include everyone that's realistically, potentially train-upable. And you're going to be coming to the meeting. You're going to be coming to the 19th, 20th meeting.
That's correct.
Yes, absolutely.
Okay, great. Because we're going to do a lot of. By the time you leave there, it will be really, really much clearer what we offer, and we hope that all of the groups who are coming will have at least a very strong first draft of what their training plan for the first half of the year will be. And we have another call that's scheduled early next week where we're going to talk, if you do have a chance to look at the PowerPoint, and we apologize that we didn't, because we were making some revisions on it all the way up until this morning. So we apologize that we didn't send it sooner. But if you do have about 20 minutes just to go through it, it sort of gives background on the overall scope of the project. It talks a little bit about why and how and what the package is, and it gives a first look, sort of an overview on the curriculum and the resources that are included. We call it the HIV training package. It's a distance learning program that's supplemented by local mentorship and distance mentorship. So I think it's something called proficiency-based, where at every stage, and you've placed yourself in stage 3, but some of the other team members, when we do the self-assessment, they might place themselves in stage 2. And there's in every part, there is a special section on women and HIV, so that your OBGYN and your PA who's working mostly in OB, there would be the general HIV business that they could catch up on, but also very specific about women with HIV and pregnant women with HIV. So there would be something for everyone.
Okay, great.
All right.
Actually, that stage 3 was pretty much because of Dr. Douglas. The rest of us are probably at, what's done is that as soon as someone's HIV positive, they sort of get turned over to Dr. Douglas. So she's in stage 3. The rest of us are in foundation.
Yeah, well, that really gives a lot of room for us to work together and to. Let me take a step back. One of the next steps that we would do, if you would have the time to look at the PowerPoint and get a little bit familiar with the package. Can I do next steps? So after this call, one of the next steps is, I mentioned that in each stage of integration of HIV into primary care, there is a set of proficiencies that we think that you need to master in order to move to up to the next stage in the sequence, right? And there's a set of proficiencies that are outlined for the prescribing clinicians, the doctors and the mid-levels. There's a set of proficiencies for the nurses. I don't know if you have any, you have 2 LPN, so there's a special one for LPN and medical assistant level. And so, there's something really in the training package for everybody. So after this call, the next thing that we would do is have one more call where, because the self-assessment forms are, we don't think they're difficult to fill out, but what we've learned is that if you go over in great detail exactly how to do it and why we're asking you to do it, then we get back a better result. So what we would do is we'd send you down these self-assessment forms, and we ask that for each member in your care team, you give them the appropriate self-assessment form that asks them to self-assess what they think their level of skill is in each of the proficiencies for their part of the care team, and then it also asks them, given those proficiencies, given those that they think they're strong in and not so strong in, which ones would they like to have in their training plan, in their individual training plan. Then we do a shuffle the deck when we get all those back, and we come out with an analysis that pretty much gives some clear guidance on what your group training plan and your individual training plans would look like for everyone in your care team. Does that make sense?
Yeah.
It'll make more sense when you have a better understanding of the package. Go through that PowerPoint, and then when you come up here in April for the meeting, we would have the self-assessments. We would have had time to analyze them, hopefully get them back to you so you could have a look. And then when you come up here, we're going to have our team. We're going to go over all those things together in a group with all of the other health centers that are participating this year. We're going to share a lot of the experiences with our teams who completed the training with us last year. And by the end of the time, when you go home after that day and a half, we're hoping that you have a very clear, at least a draft of your training plan for each of the levels in the in your care team. And then it's just a matter of finding the time and making it happen. You mentioned that you have a Thursday, Friday. I wasn't sure if it was Thursday or Friday, once a month lunch meeting. And
we have a once-a-month lunch meeting with the providers, and then we have a once-a-month center-wide meeting where we don't see any patients. We use that time to do the in-service training, do our quality improvement projects, to do our staff meetings, because we just found that trying to, even it's difficult to fit the lunch meetings in, because inevitably somebody has a patient who's late and blah, 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 blah. And after 4 years of trying to do that, Mr. Smith agreed that we could take a day to really just get all the meetings in, and I think it's working quite well. And just based on, what's coming up, we decide, for example, because we've had a surge in patients, we've gone, I think, for maybe the last 2 or 3 years, we maybe have had one emergent event all year. I think 2 weeks ago we had 3 in 1 week. So we really need to make sure everybody's up to date and do mock codes and that type thing. So we sort of tailor the in-services. We have certain risk management things that we make sure we do, but we tailor the in-service training, a little bit based on what's going on and the quality. Certainly because we're HRSA funded, we do look at a lot of the UDS measures and add some other things in to what we do on that day. So we do have that whole day, just one day a month that we reserve for training and education.
Yeah, and so hopefully we'd be able to, you know, incorporate some of the training resources in our package. We have webinars, different things that you might choose to do in that group, but also the good thing about this package is that you can also access those webinars recorded, in a recorded version, so the one who had to take care of the emergency patient and wasn't able to be there, they would just be able to go on their own time, you know, and catch up with that, I don't want to say lesson, but, you know, with that session. And because it's very flexible like that and sort of self-paced learning, the CLL needs to keep track of what the individuals are doing and have, I think, occasional group activities where everyone's together, and then people move through it in their own pace, in the way that you all have decided is realistic for your team.
Are there CMEs for those webinars?
Right. Well, not for some of them that are in the initial phase, but we'll show you when we go through the package in detail. I haven't got an exact count. We're trying to get the exact count, but there's a significant amount of activities that you can just go on to the part of our website where this material is. You could just go on there, and there's a significant amount of what we call supplemental resources that offer CME credits for those. And what we've done is we've gone and searched around. And so for each proficiency, we've done our best to find, you know, even if it's not one of our core activities, to find a supplemental resource that will give you CME credits. And I'm not sure how many, but it might be at least 50 credits that are spread out throughout the year's worth of the resources in the package.
Okay. Great.
Yeah. Yeah. Can you think of anything else? Do you have any questions?
I have a question about the staff assessment form you mentioned. Are you emailing that to us, or how are we getting that?
Right. Self-assessment, yeah. And there are going to be 3. There's going to be one for the prescribing clinicians, there's going to be one for the RNs, and there's going to be one for the LPNs and MAs. And they list all the proficiencies, and it's like a checklist, and we would email it to you in a couple of days. We don't want to send it down too far in advance of the phone call that the next phone call that we have scheduled on the 12th and 13th, because sometimes when we send it and we don't have an opportunity to explain well, they don't come back completed correctly, so we don't want to waste your time. We want to be sure that when you ask your staff to fill them in, that you yourself would have had a total explanation of what's involved. I think they're quite self-explanatory. We can send them sooner if you want to just have a look.
That would be a good idea.
You said the 12th and 13th. That's next week.
Yeah, I guess we didn't get to that. We have 2 calls that are coming up next week where we're going to review, different people from different centers would be on those calls. And, you know, that way we don't have to explain it over and over and over again. So you could look at the PowerPoint that we sent you before. If you like, we could send you the self-assessment forms so that you could have a look. But it might, unless you feel like it's absolutely clear and you're going to be able to get a very good input from your staff, you could wait a while until we have that call and you could ask any questions, or you could email us your questions if you'd like to get that assessment done sooner rather than later.
Well, the reason I asked on the date of the second phone call, of the second conference, is that the CMS is here next week, and they usually on the 12th and 13th. 2 full days of conferences that they require our presence. So,
well, okay. So in that case, we would give you an individual orientation.
Well,
and what I think.
Let me make sure as to the timeline, and then we'll get back to you on that.
Right. Okay. The call on the 12th is at noon, and the call on the 13th is at 10. We tried to make a little, variation, so if people need to do it at lunchtime or whatever. And it's basically a review of a little more specific about what's in the HIV training package and what it's all about and how it works, the roles and responsibilities of the clinical learning leader, and then just a little bit of detail on looking at those self-assessment forms and how to explain it to your care team members. Because, what happened sometime previously is that we would send them down and then they would just forward them on to their staff electronically to complete them without any explanation of what it is, how it fits into the program and all. And so then people didn't really, you know, didn't really fill them out properly. It's kind of a waste of everyone's valuable time.
Yeah.
But we'll send them. We'll send them, and if you don't, go ahead.
And Dr. Douglas is not going to be available on either of those times. Can we set up an individual time? Because I think it's very important for her to be involved.
Sure.
Right.
Steph, can we send, they're not going to be, let me just do a little conference here. They're not going to be able to do the 12th or 13th call, and would like to receive assessment forms prior. Yeah, soon. And then we'll set up, could we send them, and then they have the PowerPoint, and then they can talk with one of us? Yeah. Okay, you know, it's fine. We'll send you down the self-assessment forms. You already have now the PowerPoint. It takes about 15 minutes or so to go through, and then we can set up a call. You can let us know when, you know, when you finish. You can say, well, we don't have hardly any questions. We think we can wait until we can go ahead and distribute these forms and send them back to you, and when the meeting, you know, in April, we'll be ready. Or you can say, nope, we don't really understand this, and we'd really like to talk about these questions, and then we could set up another call.
Yeah, we can do it that way, because, yeah, those days seem to be some conflicts.
Okay, sure. And it's nice to talk, you know, individually when it's possible.
Yes.
So we'll do that. We've sent you the PowerPoint. We'll send you tonight, you know, today, the self-assessment forms. You can have a look. And if it isn't clear, then, you know, we'll have a lot of time. We'll have plenty of time to discuss that with you before you give them out to your staff, because you don't want to waste people's time doing something halfway and then having to do it over again. All right. Honestly, I think that's all the questions that I have. You did say the very last thing that you said on question 19 is that you're really having your caseload is really rapidly increasing, and you were going to have a little bit of challenge earmarking the time. But I have to say that it seems to me that you have the enthusiasm and the approach that you would find a way to manage.
Yes, that is true. Without a doubt, our load has been increasing tremendously, and however, to combat that, we are going through the process of a renovation right now, which should conclude within the next 30 days.
Oh, good. All right. So that's one down.
Yeah. We still have a second part of that project. That's the new space. And we still have to go back and enhance the old space.
Right.
Yeah, which would be a shorter process.
And what's the oral health expansion that you mentioned?
Right now, we just have 2 dental suites and one and an adult dentist, and we are about to be in discussions about trying to bring a pediatric dentist on board, and we would also like to offer a dental hygienist. So as Mr. Smith just went over, that we've made some original plans, and now we may need to change our 2 dental suites to at least 3 and maybe more. So those are the kinds of things we're looking at.
Right, and there's an oral health proficiency in the HIV training package, so that could be nice for you to go through with your dentist.
Okay.
And also, I'm just wondering, this is sort of tangential, but I'm just wondering, do you do HIV testing of your dental patients?
Everyone is encouraged. I think the short answer is probably no, but we actually have a partner called HOPE, and I can never remember what it all stands for. Helping Others, something. But anyhow, it's HOPE, and actually we have a person who's here just designated to do full-time dental. It's not quite full-time, but 40 hours a week, and we encourage her. We wear badges sometimes, ask me what's free to try to, like I said, encourage everyone, including the dental patients, because they're all in the same waiting room. But I probably do need to do or one of us will do a quality improvement study to see what the percentage of the dental patients who've actually gotten HIV testing is. And that's high as our medical patients, because we've really made more of a push on the medical side. So that's a good point that we'll incorporate that into our quality improvement.
Okay, great. Well, the group that you'll be talking to next, what time are they coming on?
Oh, they're on, and actually.
Oh, they're on.
Oh my goodness! I thought it was killing time until I heard PCBC sign in. Okay, I'm done.
And as Mona mentioned several times, the clinical section was fairly brief because we want to have another discussion with you on the HIV training package and go a little bit more in depth on how things and the clinical offerings through the project. But we also, as another part of the project, we also want to support the clinical training that you'll get through performance improvement activities. So we're partnering with the Primary Care Development Corporation, and two of their staff are on the phone right now, and they'll be leading you through reviewing some of your responses to get a better sense of the activities that they can work on with you throughout the year. The responses, again, will be used to develop a work plan for the activities, the performance improvement activities. And Patrice and Vanessa, before you introduce yourselves, I just want to let you know that one of the things that we discussed earlier on in the call was that when St. Thomas had Ryan White Part C funding, there was this reputation that that was a free service almost, and so that they're really trying to work on getting revenue for that and making sure that their patients are paying for those services. So I just wanted to make sure I told you that, so before you got to that section. Wilbur and Barbara, Deborah, did I get that correctly?
Yes.
Okay. And so I will allow Therese and Vanessa, can you introduce yourselves?
Absolutely. So first of all, we just want to say we wish we could have gotten on from the beginning, but we had a pre-scheduled meeting from 10 to 11 that we couldn't miss. And I didn't quite capture, I'm Vanessa Rudin. I'm co-lead on this project, and I'm joined by Therese, who's Corsello, who's one of our coaches. And I also will be coaching a couple practices as well as leading the project. And can I just get your names again, who's on the phone?
Certainly. Wilbur Smith.
Wilbur, okay.
I'm the ED.
Do you mind going on first name basis?
Fine.
Okay. And?
I'm Deborah Wright Francis, Medical Director. Deborah. Mm-hmm.
Okay, great.
Barbara Douglas, Internal Medicine.
Okay. Anyone else?
Just the three of us.
Okay, great. All right. Thanks, Wilbur, Deborah, and Barbara. I appreciate that. So I think we'll just go ahead and jump in. I'm going to be handling a couple sections of the practice transformation assessment that you did, and then I'll turn it over to Trace and then probably come back at the end. And I see I'm being given presenter status, so now I get to, my child is 6, so I'm at home juggling a lot of things on one computer. So hopefully I'll be able to do this. So let's see if I'm able to scroll. Okay, I have a basic question, Christine. How do I get to the next page in this document?
At the
top. Oh, maybe this arrow? Yes, there we go. All right.
And if you need me to do it, I can scroll for you.
No, it's good practice. Here we go. I managed it. Okay. So we're on the performance improvement assessment page. Does everyone see that?
Yeah.
On your WebEx?
Yes.
Yes, we see it.
Oh, yes. Okay. Sorry, it's a little bit hard to hear. In terms of your revenue maximization, Christine, thanks for letting me know about the sort of perception of Ryan White HIV services being free. I'm seeing that you have, almost half of the people you serve are uninsured, and I'm wondering how do you handle that? And basically for your HIV patients that you have now, that payer mix, is it about the same for those HIV patients that you've identified?
Because we are a 330B funded health center, that means that we have to offer the sliding scale to our patients who are uninsured or underinsured. So that's how we handle those patients who are uninsured. It's still challenging. Right now we had a minimum based on it, depending upon, and our sliding scale goes on the percentage of that people fall into the poverty level, and then most of our people are at 100%. I think it goes 100%, 200. I forget how the percentages go, but the majority of those uninsured patients qualify for the lowest rung of what they have to pay. So, which meaning that a clinic visit may be $20. Different things that they have to get done may be $20. We've just increased that minimum to $25, but oftentimes, you know, we spend a lot of time at our front desk with people in tears saying they don't even have the $20 or $25, and our mission is not to turn anybody away, but at the same time, it becomes very challenging because we have to stay in existence, and because our medical assistance program here in the islands is very different than it is in the rest of the states, we're not reimbursed at 100%. So even though we have a fair number of medical assistance patients, that's our equivalent of Medicaid, pays half, 50% of what we charge, and pays it about a year after we charge it. So it's very, very, very challenging to stay in the black. In addition to that, something that has occurred really over the last 6 months, our Department of Health, which has sort of been in the business of primary care, has decided that they no longer want to be in the business of primary care, and largely because of a lot of, you know, the economic crisis stateside has really just now poured on us. There have been massive layoffs in the territory. One of our major income sources on our sister island, St. Croix, is shut down. So, and the community clinic and the Department of the Family Planning Clinic, the Maternal and Child Health Clinic, all of which used to see at least probably the same amount of patients that we saw at their facilities. Now we've been inundated with those patients over the last 3 to 6 months. So all of our problems have probably doubled on paper, but seemingly increased exponentially. So it's very, very, very challenging because at this point we still do not want to turn anyone away, but we still have limited resources, and, you know, because as Mr. Smith said, we've been funded to take care of a small segment of the population and have quickly found ourselves taking care of the large number of the uninsured on the island and underinsured.
Yeah, I mean, having 46%, I just saw that and I was like, whoa. You know, because I know that for most, there's going to be a lot that's not collected, and the amount is so low, as you said, it's $25 is not a lot for the services that you're providing. So,
I said, and probably half of them don't want to pay that or can't.
Of course. Yeah, right, exactly, and a lot of are not paying any. So, yeah, no, I really, it gives us a good feel for your commitment to serving people, because it's certainly not for money. So really just really respect the work that you're doing. And so then I guess for the number of HIV patients that you have identified already, I'm assuming they pretty much fall in that same spectrum of uninsured, Medicaid, Medicare. Is that right?
There are probably about 25% that do have some form of insurance. But they might be underinsured. They might have really large deductibles, you know, so that they still end up having to pay money that they don't have.
Okay.
My sense, and I don't take care of a lot of them, is that it's probably the numbers are worse in the HIV population, probably more like 75 per year. What you're really saying, when you say 25, I'm asking Dr. Douglas the question, when you say 25%,
yeah.
You mean that medical assistance even and insurance,
right.
So 75% with nothing.
Right.
So it's probably exaggerated in the HIV population.
Okay. Okay.
And a large our patients, I think, a fair number of them are undocumented, which also makes it difficult for them to find employment and real employment.
Okay. So in the area of revenue maximization around HIV, what would you say would be something that we can assist you with?
And money.
Well, we were hoping you could do that, actually.
I didn't quite catch that, sorry.
No, I was just saying, you know, sometimes you don't know what you don't know. I mean, we were sort of hoping that maybe you could tell us how you could help us, you know, because, you know, there's billing of insurances, there's billing of patients, but other than that, and using the money that we get from the grants, we're really not sure what else is available. So maybe you could fill us in on that.
Well, one of the things that we intend to do, this is Wilbur, is to reapply for the Ryan White in the next budget cycle. Now, that grant was offered to the center many years ago. At the time, they were under the Department of Health, correct, Dr. Francis?
No, we were out.
We are out from under the Department of Health. But in any event, that grant was taken away for a variety of reasons. Some most unknown to us recently come into the Senate. But we do intend to reapply because I think we have turned the corner in whatever issues that the CMS found at the time of that assessment. So that's one of the areas that we intend to pursue.
Okay. All right. And then in terms of, go ahead.
What I was going to say is one of the things that I found, like I said, there's not a very, a big insured population, but even some of those who are insured are reluctant to produce that insurance card, and we don't really have a great means of finding out who has insurance, even if they don't tell us. So I don't know what exists out there in the billing world to be able to look to explore that, A. And B, I think even if we did know, we still need to combat, I think, it's a small island. There's a lot of stigma here. People are worried about their business getting out. But I think just in general amongst the HIV-infected population and those that are not, we really need to do a lot of work on the island about taking away the stigma so that they are more likely to produce the insurance card. I'd even, just to give you, for example, I had a OB patient who I needed to get some RhoGAM, and I kind of coerced the head nurse to say, will you give her one of those HIV forms that we fill out so we can get her the RhoGAM for free, which was $300. But she refused to get her RhoGAM because the paper said HIV. She wasn't even HIV infected. I would take anything that would give me $300, but she refused.
Right.
And her baby in danger because she did not want to go to the pharmacy with that paper that said that she was in the HIV program and she was entitled to get the medicine for free. So those are the kind of things at here.
Yeah. So going back to your original question, how do you think it could help us with maximizing the reimbursements?
You're asking me how do I think I can help you?
Right.
Yeah, I actually have to think about it because you're definitely under more pressures than, most practices, especially with so many uninsured. I would probably want to look and see of those that you do know the insurance for, are you maximizing your income from those people?
I think that's kind of. This is Dr. Wright Francis. We could definitely use some help with the coding and proper coding and counseling. For example, I know a lot of those patients, are sometimes take an hour for Dr. Douglas to see to make sure that she's using the proper codes to show that been an hour with them. And I think even because we code this, we should be coding the same for all our patients. If we are properly coding and even can show the federal folks who fund us that this is what we're doing and this is how much we're charging, even though we're not getting the money back, that would also maybe help us to be able to get more funding just in our general grant.
Right, and then I guess the other piece would just be, are there aspects of the Ryan White that if you improve certain things, they would trust, whatever, they would be more likely to select you. So I don't have the answers off the top of my head, but I think we can look at those different avenues and then also work with you on that piece that you said about people, the stigma. It relates to another section that we're going to go over, cultural competency, which is to increase your rate of being able to get insurance cards from people who actually do have it. So those are some of the areas that we can definitely look into. Why don't we move on to the next section? So let me just, Therese, before I go on, was there anything else that you wanted to ask in this section?
No, I think we got a good amount of information there. So.
Okay.
And certainly we do want more input because I think we still have a lot of folks who are, as we try to get everybody tested for HIV from the quality improvement point of view, that we certainly would welcome your input about any PDSA that you would offer for us to be able to improve those numbers.
Of how many people are tested?
Yes.
Yeah, and actually we're going to get to that section, but I have a question for you. So I'm assuming if they have insurance, you test them, you get paid. If they're uninsured and you test them, then you're still back against whether they're able to pay you.
Yeah.
Okay.
Actually, we really just offer the free HIV testing to everyone without any, because we have partnered with the program where someone's here, that we do offer free testing to all the patients and even on a walk-in basis. Sometimes on Fridays when that person is not here, we will order it and then we'll order it through our lab and then it becomes a billable service. But that's very rare. But, you know, maybe you've hit on a great point. Maybe we need to start billing those people who can pay, who have insurance.
Yeah, so that's something we can explore as long as, obviously the goal is to get everyone tested, but if the insurance is going to pay for it and they don't have to, then we should potentially look into that. So, okay, good. So that's really excellent information. And then I'm just noticing that it says, no, you don't have a report on why healthcare claims are rejected. I just want to check in with that. So when you do submit claims, you don't you don't do any investigation of why they're rejected, or?
Did you run that by Ms.
Yes, I got all of these answers from our billing person who is not in the room, and
okay.
So I really am not able to expound. I mean, I think she's there in hopes that with our new system that some of these things will be incorporated in. I think they have some very antiquated ways of sort of keeping up with when the bills have not been paid, and maybe some manuals, you know, some manual logging, but it would be probably not correct for me to expound much more than that, because
that's fine. I think that's something once we decide what the priority areas are, we can we can explore that in more depth. But you brought up something else that I had meant to ask you at the beginning. So I had noted from somewhere, maybe in your application, that you have NeoMed as an EMR. Is that correct? And are you moving to that or away from that?
No, we are going to implement that process with NeoMed. Let me go back to answer the question you asked prior.
Okay.
We are installing a new practice management system that will give us the capability of differentiating those kinds of questions that you asked before.
Okay.
The billing and follow-up of those claims that may have been denied.
Okay.
Yeah, the system that we have currently does not have in it those kinds of parameters.
Okay.
So
what do you have currently?
I think it's Chorus. Chorus. It used to be MD-Serv. They're now Chorus, but we're moving away from them and going with the more up-to-date intelligent system with Evertech, which NeoMed is part of that application, which the EHR will be. But we are also installing a new practice management system as well as accounting system and registration.
Okay, so let me just see if I understand. So NeoMed integrates well, or Evertech is part of NeoMed?
Evertech is the overarching company. And
okay. And so you're going with the practice management system that's part of Evertech, and they also make NeoMed?
Yes.
Okay. All right. So it should be more integrated and easy to use.
That is correct.
Okay, great. And when is that happening?
That should, well, I say before the end of the year.
Okay. So by November or December?
Yes. That would happen before that, but I'm giving that outlier date.
Oh, okay, right. Okay. No, yeah. Under promise, over deliver. So, okay. It just gives me a ballpark. Okay. So then, yeah, let's move on to the quality improvement side that we just started to touch on. Let's see if I can get, here we go. You mentioned that it's HIV testing for people who are eligible. Who's eligible?
What number are you looking at? If I wrote that, it was a mistake.
Oh, I'm looking at 25, and it says we've set a goal.
Eligible. I just meant that, you know, we weren't really trying to test the little children who were 10 or 11, and we do have a big pediatric.
I see.
That's what I meant by that. And I'm
sorry.
sorry.
Okay, right.
Eligible.
Yeah, well,
Over a certain age, basically.
You know, and I don't know. What is the age? 12 or sexually active? That's what I meant was just we don't offer it to our little.
Okay. Okay. And I may have missed this, and you may have already shared this. I apologize for asking you again, but do you know what your current percentage is that have been tested?
Last year we tested 607, and we had 4,000 patients on the roster. But according to our system, that's not quite that great. So I don't know what that calculation is, and probably. Are some duplicates because of the pregnant clients. Towards the end of the year, we started retesting the pregnant clients. So, you know, maybe 50 of those might be repeats. So, but the number we have is 60. Yeah.
Okay, so, I mean, it's about, I would say like 15%, something like that.
15%, and I can tell you that probably of those 4,000 patients, probably 2,000 are under 12.
Oh, right, of course. Yeah, so, so probably 30% of adults. I mean, just to get a ballpark. So we're, okay, so that, you know, there are many practices that have, you know, have not tested many at all. So you're ahead of the curve against a lot of FQHCs. So that's great starting point. And then it sounds like you have a robust quality improvement and that you've engaged most of your staff in it, and then we just wanted to hear a little bit more of how that started and how do people get trained in PDSAs and that kind of thing.
Well, the honest truth is, up until about 2 years ago, myself, and I comprised the quality assurance team, and after the feds came down and said, thank you very much for your efforts, but that is no longer acceptable, and we must do things differently. We spent the last 2 years doing it very differently. So the pendulum had swung from one extreme to the other, where it was the team of me till Mr. Smith agreed when he came on board that we would engage everyone in quality improvement. And that's what we've done. So having those monthly meetings, and it's really been a slow process in engaging everybody. I myself had really never heard the term quality improvement before I came on board here about 6 years ago, and have had the help of the community and help of some consultants coming in from HRSA to help us do that. So over the last 2 years, we've really put it into play, and really over the last 6 months, when we've had all these providers here to actually, I've sort of, delegated a lot of the work out and doing a lot of the teams and having everybody involved with collecting data, looking at what's going on. It's really started to come together really just in the last 6 months. And that we've had, really up until 6 months ago, we were struggling just to have a provider to see patients, and we're really sort of running a women's clinic with a little help from Dr. Douglas doing some internal medicine here and there. So, the center looked very different 12 months ago.
Wow, it sounds
that with a lot of help and from a lot of people and a lot of positive input to go forward. And we just redid. We have FTCA coverage, which is the Federal Tort Claims Act, and we had some folks come down from HRSA, and I can tell you they had a lot of fire on us to really get our quality assurance programs up to date. Dr. Douglas can attest to the many boring meetings where I've gone over the quality assurance plan page by page so that everybody is now saying PDSA in their sleep. But it's been painstaking, and it's still in its infancy at best. But I think everybody sort of knows what it means, and it's really started to realize that we're always doing quality improvement, even when we just say, whatever we're doing, but just have really sort of started to incorporate the terminology into our everyday use and putting the names on it and trying to be more, trying to make things measurable and quantify what we're doing versus doing a lot of anecdotal.
And one of the things
that's great. I mean, what I hear two things. Oh, go ahead. Sorry.
Yeah, one of the things that we've impressed on the staff is that quality improvement is not just clinical. And so, again, we had to actually get staff to buy into the concept that the quality improvement issues are a global center issue, and not that just what has to do with the clinical side of the organization, but including the administrative side in all parts of the organization, as whatever we do with the one goal in mind of ensuring that the patient has access and given the opportunity to have quality care.
Oh, that's terrific. And you mentioned that everyone's involved in collecting data, so you're having front desk staff help collect data, MAs help collect data, is that right?
Data is collected all over this institution that you would want to. Yes, that is correct. That is correct.
Okay, so okay, good. So
one of the things that we do is, and show you familiar with the UDS reporting format back to the feds. Well, again, that in itself is a challenge, and so everyone now has an opportunity to understand what that is, and it's not just data collected by one or two individuals and then you put it in the computer.
Right, okay. And do you think, and then we probably better move on, but do you think, I've certainly had practices where I got to the point where everyone was collecting data, but do you think you've gotten over the hurdle where they understand what the data is telling them? And remember, I'm not reviewing, I'm here to support you, so you don't have to look good. So you can say, yes, they do, we're over that, or some do and some don't, because we're here to help design something that will strengthen you even further.
Well, it's the latter. Some do, some don't.
Okay.
Because
it's a huge challenge to go from, okay, I'll give you the data, you asked me for it. Well, no, you go from, I'm not, every excuse in the book for not doing the data to, okay, here's the data, you asked for it, to people actually going, oh, actually let me show you the data because I just noticed such and such. So it sounds like you're kind of between step 2 and 3.
Yeah, I hadn't heard that, let me show you the data. Few of the docs, it's been a little bit slower going with like our medical assistants as we okay, you have to make sure you write down the BMI and this is why this is important. And that sort of thing. So yeah, we're not there yet, I don't think. Dr. Douglas.
Well, we're sort of getting there because Dr. Wright Francis, in the meetings that we have once a month, we have in-service training where different people get up and give lectures on different issues. So we're trying during that type of forum to inform the medical assistants and the other people on the staff exactly what the numbers mean.
Yeah.
Okay. So, so it sounds to me like, and we definitely, everything we do is going to be centered around your HIV goals, but you can do a lot around having people own the data that's associated with your HIV goals. And so we're going to be creating a proposed work plan and then reviewing that with you to say, hey, this is what we heard from you when we did the assessment, here's our thoughts. Does that resonate or should we shift it? So this is good information. It's giving us, you're giving me some ideas, and I'm assuming Teresa's, her wheels are turning as well. So let me just ask you a little more open-ended question. Where do you want help with improving quality for HIV-related testing and clinical care goals?
I think, as we mentioned before, where we need probably